Hello dear students, good evening and welcome to this Physiology Rapid Recap session for the INI-CET November 2023 exam. Physiology is a high yield subject, as you will be aware by now, and there are these very frequently repeated topics which we are going to discuss today. Also the important topics which have been asked in the last 3 to 4 years exams. We will be concentrating on these today, on all these high yield topics. So without further ado, let's start today's session and let's see the first one. First is on the feedback system, a favorite topic of INI-CET. There are two major types of feedback systems. There is a negative and there is a positive feedback system. Now, as far as the negative feedback systems are concerned, majority of the control systems in the body function on negative feedback. Negative feedback systems are stabilizing. They help to maintain homeostasis. What is homeostasis? Homeostasis is maintenance of nearly constant conditions of the internal environment. Maintenance of the ECF osmolality at 290 milliosmoles per liter, maintenance of body temperature at 37 degrees Celsius, maintenance of blood pressure. All of these are controlled by negative feedback mechanisms. Now, what is characteristic feature of the negative feedback mechanism is this: there is a reversal of the initiating stimulus. So what do I mean by that? For example, when there is an increase in the mean arterial pressure due to any cause, this will stimulate the baroreceptors. Baroreceptors, once they are stimulated, what are baroreceptors? These are stretch receptors. So if the mean arterial pressure increases, there is increased stretch of the vessel wall, stimulation of the baroreceptors, which will cause a reflex decrease in the sympathetic supply to the cardiovascular system. So when the sympathetic supply decreases, there is going to be a vasodilation and there is a decrease in the total peripheral resistance, which will cause reversal of the initiating stimulus. What was the initiating stimulus? Increase in blood pressure. So keep in mind that there is a reversal of the initiating stimulus. Let's take another example. Now, supposing there is a fall in blood pressure. Maybe there is blood loss and there is a fall in blood pressure. Yes. Now, the baroreceptor stimulation reduces and this in turn causes an increase in the sympathetic discharge to the cardiovascular system, which will cause a vasoconstriction, increase in total peripheral resistance, and it will cause increase of the blood pressure to bring it back to normal. Again, there is a reversal of the initiating stimulus. Initiating stimulus in this case was a fall in blood pressure. So this is now going to increase. So this is your negative feedback mechanism. Keywords, please remember: reversal of the initiating stimulus. Now, what happens in a positive feedback? There are fewer examples. This is not stabilizing. Here, the initiating stimulus is further enhanced. And the examples of positive feedback is clap, clotting. This is a positive feedback mechanism. Calcium release from the sarcoplasmic reticulum during a muscle contraction. That is also a positive feedback mechanism. That is something known as a calcium-induced calcium release. L stands for LH surge. The milk let down reflex. LH surge just before ovulation is because of positive feedback of estrogen on LH. Estrogen increases LH, which in turn increases estrogen, which in turn causes increase in LH. So there is a sharp increase in LH just before ovulation. Milk let down reflex is also an example of positive feedback. Action potential. The depolarization phase of action potential is positive feedback. The activation of the inactive pancreatic enzymes to their active form, that is also an example of positive feedback. P stands for parturition. And if I add shock, my acronym becomes SHOCKS. These are all examples of positive feedback. Which type of a shock is an example of positive feedback? This is a decompensated or an uncompensated shock. That is an example of positive feedback. Now, there is something known as a gain of a negative feedback system. Again, a important topic from an INI-CET point of view. And what is gain? This is correction over the error. And there was an INI-CET question which was asked, and that said that a man gets up from the lying position. Once he stands up, there is a fall in his blood pressure by 10 millimeters of mercury. The baroreceptors will correct his blood pressure by 8 millimeters of mercury. How much is his gain? So, is the gain 2, 4, 6, 8? What is going to be the gain? And I just told you gain is the correction over the error. How much is the correction? It's given in the question. Correction is 8 millimeters and the error is 2 millimeters. How is the error 2? The fall in his blood pressure was 10. Correction is 8. So there is still an error of 2. In other words, what is his gain? Gain is 4. This, the concept of gain has been asked at least twice in the INI-CET exam. There is one mechanism which has an infinite gain. How do you get an infinite gain? When the error is 0. Error is 0, gain will be infinite. And there is only one mechanism which has an infinite gain, and that is the maintenance of the ECF volume by the kidneys. Renal body fluid mechanism. The role of kidneys in maintaining the ECF volume, that is, has got a 0 error and an infinite gain. Let's have a look at this particular graph here. Now this is trying to show you what is going to happen if there is a right. So this is if there is blood loss. Let's see this first example. There is blood loss of 1 liter. Baroreceptor renin-angiotensin mechanism has brought the blood pressure back to normal. So that is negative feedback. But see what has happened here. When the bleeding is excessive, 2 liters, now the body's negative feedback mechanisms are not able to bring the blood pressure or the pumping effectiveness of the heart back to normal, and this leads to death. So this is because of a positive feedback. Returning back to normal will be negative feedback. When the blood loss is mild to moderate, there is a the body's negative feedback control systems will bring the blood pressure back to normal. And when the bleeding is excessive, then there is loss of then the positive feedback mechanisms are set into motion and it leads to death. So remember, uncompensated shock or a decompensated shock is an example of positive feedback. Right, so let's go on to the third type of feedback system, or the third type of control system, which is known as feed forward, or the feed forward, or what is known as the adaptive control. Feed forward or the adaptive control. Now, what is feed forward or adaptive control? The important key word here is it is an anticipatory control. It is an anticipation. That is what is known as a feed-forward control, anticipatory control. Now here, the examples of feed-forward control, for example, salivation in anticipation of food. This is known as a feed-forward control, anticipatory control. Or let's take another example, when there is increase in the blood pressure, heart rate, even before the onset of exercise. Once exercise starts, at the onset of exercise, it is because of the activation of the joint proprioceptors. But before onset of exercise, there is an increase in the sympathetic discharge, increasing the blood pressure and heart rate. That is an anticipatory control. There is a, let's say, there is an increased sympathetic discharge. For example, when you are, when there is the outside temperature is very low, let's say in winters, even before you step out of the house, there is an increased sympathetic discharge which produces a peripheral vasoconstriction to minimize heat loss. That is also a anticipatory control. Even before you're exposed to cold temperatures, there is a peripheral vasoconstriction. So that is your examples of feed-forward or anticipatory control. Now, remember, when it comes to temperature regulation are both feed-forward as well as negative feedback mechanisms, both. Feed-forward, like I just told you, anticipatory, and negative feedback is when there is an actual fall in the core body temperature, and the negative feedback mechanisms will help to bring the body temperature back to normal. So remember, temperature regulation is both an example of feed-forward and negative feedback. Feed-forward acts much more rapidly than the negative feedback. Right, so let's go on to look at another example of feed-forward control. Now, supposing there is an increase in the dietary intake of potassium. Now, the gut has got potassium sensing receptors, and they immediately cause an increase in the renal excretion of potassium, and they increase the potassium uptake in the muscles. This is even before there is an increase in the plasma potassium levels. So this becomes a feed-forward control. But if there is an increase in plasma potassium levels, which now increases aldosterone, and that affects the kidney, that will be known as the feedback control, the negative feedback control. So remember, feed forward, the key word is anticipatory. Any mechanism where there is an anticipatory. For example, like I just told you, if you're increasing the dietary intake of potassium even before the plasma potassium level rises, directly there is increase in the renal excretion of potassium and increased uptake of potassium in the muscles. That is a feed forward control. But when the plasma potassium level rises, increases aldosterone, increases the potassium loss from the kidney, that is, and then brings the plasma potassium levels back to normal, that is a negative feedback mechanism. Absolutely. So any questions, you can put it on the chat and I'll have a look and I can, yes. So good evening everyone, and if there are any questions, let me know. All right, so negative feedback, positive feedback, feed forward. We should be absolutely clear because like I told you, these are important from your INI-CET exam. What is the concept of gain, correction over error should also be absolutely clear. Let's see the next thing. Now, when you look at this first graph here, this is showing you, so whenever you have a graph in the question, have a look at the what is on the x-axis, in this case concentration, and what is on the y-axis is the rate of transport. So a linear relationship, more the concentration gradient, more the rate of transport. This is seen in simple diffusion. Transport is directly proportional to the concentration gradient. This is seen in simple diffusion. But what happens in a carrier-mediated transport? More the gradient, more the rate of transport, till it reaches a transport maxima. There is a maximum rate of transport which is going to be seen in a carrier-mediated transport. Why is there going to be a maximum rate of transport? This is because the carrier proteins tend to get saturated. An example of the carrier-mediated transport is facilitated diffusion. And in facilitated diffusion, as you can see from this diagram, and by the way, this has also been asked, exactly this diagram was given. If you can see the substance which has to be transported, it binds with the carrier protein. There are carrier proteins which are involved, and then there is a conformational change and the substance is transported into the cell. So that is a carrier-mediated transport, facilitated diffusion. And whenever there are carrier proteins which are involved, there is going to be what is known as saturation kinetics. What is saturation kinetics? There is a maximum rate of transport and there is going to be a transport maxima. A maximum rate of transport will be present. So please remember, in a simple diffusion, it is a linear relationship, more the gradient, more the rate of transport. In a carrier-mediated transport, such as facilitated diffusion, there is going to be a transport maxima, a maximum rate of transport because of saturation. What is this here? This is known as the Fick's law of diffusion. Fick's law of diffusion is again something which has been asked earlier. This is applicable to all substances which move by simple diffusion. Which are the substances which move by simple diffusion? Respiratory gases, lipid-soluble substances. J is equal to minus dA delta C by delta X. What is D? D is the diffusion coefficient, which is specific for every substance. Diffusion coefficient is directly proportional to the lipid solubility of the substance. It is inverse to the molecular diameter. It is inverse to the square root of the molecular weight. A is surface area. More the surface area, more the rate of transport. Delta C is concentration gradient. Delta X is the thickness of the membrane. This is the Fick's law of diffusion. So Fick's law of diffusion says that transport will be directly proportional to diffusion coefficient, directly proportional to the surface area, directly proportional to the concentration gradient, but inverse to the thickness of the membrane. And we can apply this in a clinical setting as well. A patient of interstitial lung disease, or patient of pneumoconiosis or asbestosis, where there is increase in, or pulmonary fibrosis, there is increase in the thickness of the respiratory membrane. If there is an increase in the thickness of the respiratory membrane, what will happen to the rate of transport? Reduces. What happens to the diffusing capacity in restrictive lung diseases? Reduces. So this is Fick's law of diffusion. So we've done two very important questions or previously asked topics. Number one, we've discussed this graph which has been asked earlier. Number two, we've discussed Fick's law of diffusion. And number three, we've also discussed facilitated diffusion and how the substance being transported by facilitated diffusion binds with the carrier protein, and therefore it is a carrier-mediated transport. And because it is carrier-mediated, there is going to be a transport maxima. Now, active transport, if you look at active transport, there is a primary, there is a secondary active transport. Examples of primary active transport. Now, what is the difference or the characteristic feature of active transport? Energy is required. Energy is required. And number two, it is against a electrochemical gradient. This is an uphill transport. It is against an electrochemical gradient. Active transport can be primary or secondary. Primary is sodium potassium ATPase, Na plus K plus ATPase, H plus K plus ATPase, which is also called the proton pump. This is present in the parietal cells of the stomach involved in the secretion of HCl. SERCA, sarcoplasmic endoplasmic reticulum calcium pump. This is present in the sarcoplasmic reticulum of muscles. This will pump the calcium back into the sarcoplasmic reticulum. So these are your primary active transports. Now, secondary active transport can be a co-transport or symport, and it can be a counter-transport or an antiport. An example of a co-transport is SGLT. Let's have a look over here. This is the PCT cell. On the basal side of the PCT cell is the sodium potassium ATPase, which pumps out 3 sodium and brings in 2 potassium. Activity of the sodium potassium ATPase on the basolateral membrane creates an electrochemical gradient for sodium. So what do we find on the luminal side? Sodium will move along this electrochemical gradient, and the movement of sodium provides the energy for active transport of some other substance. In this case, glucose. That is why it is known as SGLT, sodium glucose linked transport. This is an example of secondary active co-transport. Why is it called secondary? Because it is dependent on primary. Primary creates an electrochemical gradient for sodium, and that is what causes the movement of sodium from outside to inside, and movement of sodium provides the energy for active transport of some other substance. Other substance moving in the same direction as sodium, co-transport. If it moves in a direction opposite to the direction of sodium, that is known as a counter-transport. So PCT, intestinal epithelial cell, you have SGLT, sodium amino acid co-transport, but please remember PCT, the main subtype is SGLT2. In the intestinal epithelial cell, it is SGLT1. The main protein is SGLT2 in the PCT and SGLT1 in the intestinal epithelial cells. Thick ascending limb, Na plus K plus 2 Cl minus co-transport. DCT, Na plus Cl minus co-transport. Thyroid cells, you've got the sodium iodide symport. Counter-transport in the PCT, Na plus H plus antiport, and myocardial cells, sodium calcium counter-transport. Now, this is again an important topic from the INI-CET point of view. Sodium iodide symporters, where can you find them? Not only in the thyroid cells, they are also present in the salivary glands, in the gestational and lactating breast, stomach, intestinal epithelium, and as well as in the placenta. So this was a question which has been asked, that sodium iodide symporter is present in all except, and your answer there was the pituitary, or the options were pituitary, salivary gland, thyroid, and the placenta. The answer, of course, is pituitary. Pituitary do not get the NIS, but all the other areas, starting from salivary gland, thyroid, gestational and lactating breast, stomach, intestinal epithelium, as well as in the placenta. Sodium iodide symporter. Let's have a look at the next concept, and this is exocytosis and endocytosis. Exocytosis. Exocytosis, where the contents of this vesicle have to be exocytosed. The vesicle will dock with the membrane, and there is exocytosis of the contents. Which are the proteins which are required? Syntaxin, synaptobrevin, and SNAP25. These proteins are required for exocytosis. These are also called docking proteins. They help the vesicle to dock with the cell membrane, and then the contents are exocytosed. They move out of the cell. Now, one important area where you get exocytosis is the neuromuscular junction. Neuromuscular junction, there is exocytosis of acetylcholine. Now, botulinum toxin, it acts on these docking proteins, it inactivates these docking proteins, and there is no exocytosis of acetylcholine, and it produces what is known as a flaccid paralysis. Site of action will be the neuromuscular junction, right? Now it inactivates these docking proteins and there is flaccid paralysis. No release of acetylcholine, flaccid paralysis. Now botulinum toxin is of 8 types. Type A, B, C1, C2, D, E, F, G. Now what is toxic in humans? Toxic in humans is A, B and E. These are toxic in humans. The other subtypes of botulinum toxin act in animals. Now, botulinum toxin B inactivates synaptobrevin. A and E inactivate SNAP25. Tetanus toxin also inactivates synaptobrevin, but the site of action of the tetanus toxin is the spinal cord. Botulinum toxin, neuromuscular junction, the tetanus toxin is at the level of spinal cord. Tetanus toxin causes a spastic paralysis. Botulinum toxin causes a flaccid paralysis. The sites of action are going to be different, but they are both inactivating they both inactivate synaptobrevin. And again, this is a question which has been asked in the INI-CET exam. Tetanus toxin acts on which docking protein? And that is synaptobrevin, but the site of action, spinal cord. Endocytosis. In endocytosis, just 1 second please. Just give me a minute. Sorry, my phone had run out of charge. All right. So what happens in endocytosis is, now here which are the proteins which are going to be required? Now endocytosis, for example, phagocytosis and pinocytosis. Now a substance which has to be endocytosed, the cell membrane will first surround that substance and then it forms a vesicle. The proteins which are required are clathrin, caveolin and dynamin or what is known as pinchase. So this is exocytosis and endocytosis. Now another important table again has been asked, not only in INI-CET but also the NEET PG exam. So ECF is rich in sodium. It is rich, it has a higher content of calcium, chloride, bicarbonate. ICF on the other hand is rich in potassium. So a sodium rich potassium poor fluid is the ECF and sodium poor potassium rich will be the ICF. Another important point, which is the most important buffer in the ECF, is bicarbonate. In the cells in the ICF is phosphates and proteins. More important than proteins, phosphate in terms of concentration, but in terms of buffering action, proteins are more important than phosphates. In terms of concentration, phosphates are more, but in terms of buffering action, proteins are more important. Another important point, and that is look at the pH. pH is 7.4 in the ECF, slightly lower in the ICF. Again, a question which has been asked, which of the following is higher in the ECF? And your options were proteins. Proteins, as you can see, are higher in the ICF. Phosphates, higher in the ICF. C, osmolality. Osmolality is the same in both the ECF and ICF. And the fourth option was pH, and as you can see, the pH is higher in the ECF, slightly lower, 7.1 in the ICF. So this is again an important table. Osmolality, remember ECF osmolality is 290 milliosmoles per liter, ICF is also 290 milliosmoles per liter. But another question which was asked, which is the most osmotically active particle in the ECF? Sodium. Which is the most osmotically active particle in the ICF? Potassium. So this is your, this is, like I said, an important table from an examination point of view. All right, let's look at the next slide, and this is the Nernst equation. Now, Nernst equation, again, a favorite topic as far as the INI-CET is concerned. You have been asked, but of course not very recently, but you have been asked to calculate the Nernst equation. Now firstly, or the Nernst potential using the Nernst equation. So Nernst equation is used to give us the magnitude of, this gives the magnitude of equilibrium potential of a freely diffusible ion. So whenever the cell membrane becomes freely permeable to an ion, the magnitude of potential difference for this ion at equilibrium, which is known as the equilibrium potential or the Nernst potential, can be calculated by the Nernst equation, right? So remember, what does the Nernst equation give you? It gives you the magnitude of the equilibrium potential, a question which has been asked, which is also called the Nernst potential. But remember, when do you calculate the Nernst potential? When the cell membrane is freely permeable to that particular ion. Now, what is the Nernst equation? This is equilibrium potential is 61.5 divided by Z. And what is Z? Z is valency log of C1 by C2. This is higher concentration. C1 is the higher concentration and C2 is the lower concentration. So Nernst equation for magnitude of the equilibrium potential. Now, what is the Goldman-Hodgkin-Katz equation? Goldman-Hodgkin-Katz equation is used for the calculation of resting membrane potential. Goldman-Hodgkin-Katz equation says that the resting membrane potential in millivolts is minus 61.5 log of concentration of chloride outside the cell divided by concentration of chloride inside the cell into permeability of the cell membrane for chloride plus concentration of potassium. Now remember, for negatively charged ions, the outside concentration is in the numerator. For positively charged ions, inside concentration is in the numerator. So concentration of potassium inside the cell into permeability of the cell membrane for potassium divided by concentration of potassium outside the cell into permeability of the cell membrane for potassium plus concentration of sodium inside the cell into permeability of the membrane for sodium divided by concentration of sodium outside the cell into permeability of the membrane for sodium. Please remember, for negatively charged ions, outside concentration is in the numerator. For positively charged ions, inside concentration is in the numerator. Now we know that at rest, the permeability of cell membrane for potassium is much more than that for chloride, and which is more than that for sodium. In fact, the sodium permeability is almost 0. Anything multiplied by 0 is 0. So two extremely important questions here. Which ion contributes maximum to resting membrane potential? And your answer is potassium. Why does potassium contribute maximum to resting membrane potential? Because the cell membrane at rest is maximally permeable to potassium. Which ion does not contribute to the resting membrane potential? Sodium. Why? Because the cell membrane is almost impermeable to sodium at rest. Which is the most diffusible ion at rest? Potassium. And potassium is contributing maximum to the resting membrane potential. When I say a membrane is most permeable to potassium, that means maximum number of leak channels which are open at rest are those for potassium. Let's see the next slide. Again, important, has been asked, again a PYT, which is what is the membrane conductance for sodium and potassium during the different phases of action potential. As you can see over here, there is a graph of action potential which I've given you over here. There is the depolarization phase, which is because of opening of fast voltage gated sodium channels, which increases the sodium influx. Then you have the repolarization phase. Repolarization phase is due to closure of the sodium channels. Remember, sodium channels are fast channels, fast to open, fast to close. So closure of sodium channels, decrease in sodium influx, and opening of the slow potassium channels, increase in potassium efflux. So when you look at these two graphs, sodium conductance and potassium conductance, when I give a stimulus to a cell, the fast voltage gated sodium channels will open first, as a result of which sodium will come from outside to inside. There is an influx of sodium, gain of positive charge, and the potential of the cell will go from minus 70 millivolts, which is the resting membrane potential. It will go towards less negative values, reach zero, and even cross zero to go up to plus 30. This is the depolarization phase because of an increase in sodium conductance. Then the sodium channels close and there is a decrease in sodium conductance. What about potassium conductance? Potassium conductance at rest is higher than sodium conductance. Like I just told you a little while back, that the resting membrane potential is mainly because of potassium. When I give a stimulus, the potassium channels are slow channels. They are slow to open. And once the potassium channels open, there is going to be movement of potassium from inside to out. Loss of positive charge will be responsible for the repolarization phase. So these two graphs become extremely important, the sodium conductance and the potassium conductance. Once again, depolarization is because of sodium influx due to opening of fast voltage gated sodium channels. Repolarization is because of closure of sodium and opening of potassium. So depolarization because of increase in sodium influx, repolarization because of a decrease in sodium influx and a increase in potassium efflux. So these are your two important graphs regarding membrane conductance. Let's see the next one. This is a sarcomere. Now this shows you, this is an electron microscope picture. This is the Z line. This is another Z line. And C, which is between two Z lines, this is the sarcomere. A is the dark band. And what is the dark band? This is myosin plus the overlapped actin. Within the A band, there is a slighter lighter area, which is the H zone. And what is H zone? Only myosin. This E is the light band. And light band is only actin. But please remember, half of the light or the I band lies in one sarcomere, half lies in a neighboring sarcomere. So when I look at a sarcomere, there is half of I band plus the A band or the dark band and half of I band. So that is what a sarcomere consists of. This is half of I band plus A band plus half of I band. This is a sarcomere. Again, this has been asked as a question. Dark band, myosin plus overlapped actin. H zone, only myosin, and I band is only actin. What happens to these different bands during a muscle contraction? The I band will slide into the A band. So I band reduces, H zone reduces or even disappears, and which band remains unchanged during a muscle contraction? And that is the dark or the A band. It remains unchanged during a muscle contraction. So this is as far as the sarcomere is concerned. Again, a question from the neuromuscular junction which is being asked: Lambert-Eaton syndrome and the myasthenia gravis. Clinical scenarios have been given and you have been asked to identify the disease. Lambert-Eaton is a disease of the presynaptic membrane where antibodies are against the voltage-gated calcium channels on the motor neuron. And myasthenia gravis is a disease of the postsynaptic membrane where antibodies are against the acetylcholine receptors. Clinically, both can present with ptosis, drooping of eyelid. But in the case of Lambert-Eaton syndrome, the maximum weakness is in the mornings and the weakness improves as the day progresses. Why does the weakness improve as the day progresses? This is because when you're repeatedly stimulating the alpha motor neuron, more and more calcium tends to accumulate, increasing the release of acetylcholine. So weakness improves as the day progresses. But in myasthenia gravis, the maximum weakness is in the late evenings. This is a disease of postsynaptic membrane. Repeated stimulation is causing more and more release of acetylcholine, so there is a depletion of acetylcholine. So weakness here in fact worsens as the day progresses. Here the patient will tell you that morning he feels okay, but towards the evening he feels fatigued and he feels that there is muscle weakness and he's unable to perform his day-to-day activity, and this weakness improves after rest. That is a typical history given by a patient of myasthenia gravis. So again, an important topic from your INI-CET point of view. Let's see a question which has been asked in the last INI-CET, and that was length-tension relationship. This graph was given and you had the initial length on the x-axis and the tension generated on the y-axis. This is also known as the Frank-Starling's law. And what is the Frank-Starling's law? More the initial length, more will be the tension generated, but up to a physiological limit beyond which further increase in initial length will decrease the tension generated. This is the Frank-Starling's law or the length tension relationship. More the initial length, more is the tension generated, but up to a physiological limit beyond which further increase in initial length decreases the tension generated. Okay. Now, this is applicable to the heart. So when you look at the ventricular muscle fibers are circular. What can cause an increase in the initial length of the ventricular muscle fiber? more venous return, more filling, more end diastolic volume. More the end diastolic volume, more will be the initial length, and more will be the tension generated, more the stroke volume, more the cardiac output, but up to a physiological limit, beyond which further increase in initial length decreases the tension generated. See what will happen in a patient of dilated cardiomyopathy. In a patient of dilated cardiomyopathy, the initial length of the ventricular muscle fibers is very large, but the tension generated is less. Why? Because the initial length has gone beyond the physiological limit. So this is the Frank-Starling's law, or the length tension relationship. Yes, EDV is the end diastolic volume. Okay. All right. So S, you wanted to know what is after depolarization and hyperpolarization of the action potential. After depolarization is because of a decrease in the rate of potassium efflux, and hyperpolarization is because of slow closure of the potassium channels. Is it all right? Okay. Okay. Thank you, S, for your compliment. Thank you very much. All right. Tetanizing frequency. Now, as far as tetanizing frequency is concerned, again, you have been asked to calculate the tetanizing frequency. What is tetanus? Tetanus is a state of sustained contraction. And that means when I repeatedly stimulate a muscle, it goes into a state of sustained contraction. For example, you are sitting on your table and chair, and your paraspinal muscles are in a state of sustained contraction. They are in a state of physiological tetanus. You're writing, hopefully writing your notes as well as you're following this session. That means your small muscles of the hand are in a state of physiological tetanus. So how do you calculate the tetanizing frequency? This is 1 upon the contraction period in seconds. 1 upon the contraction period in seconds. And you were given a graph and you had to calculate the contraction period. So as you can see over here, you have to exclude the latent period. Latent period is not to be included. Latent period appears to be about 5 milliseconds here. So if this is 10, 20, 30, so approximately 35 is the contraction period. So 1 upon 35 milliseconds, you have to convert it into seconds, so 35 upon 1000. So this will be 1000 divided by 35 per second. So this is as far as your how to calculate the tetanizing frequency. What you have to keep in mind, the contraction period. Firstly, latent period is not to be included. Contraction period has to be in seconds. So if it is given in milliseconds, convert it into seconds. What is a millisecond? 1,000th of a second. Right, absolutely. Yes, Shovik, so you've made a little mistake here, Shovik. You took it as 40 as the contraction period. Remember, there is a small latent period which is given, which appears to be about 3 to 5 milliseconds. Yes, the point I'm trying to make is, Shovik, I hope you've understood that please do not include the latent period. It has to be contraction period in seconds. All right. Okay, so this is an Pacinian corpuscle. Again, the receptors are a favorite topic as far as INI-CET is concerned. Now, this is a rapid recap of all the INI-CET PYTs. So, we are going to cover as many as possible. Pacinian corpuscle, as you can make out, it looks like a cut onion. Yes, the A beta nerve fiber, which is a large diameter myelinated nerve fiber, the tip of this nerve fiber is encapsulated. It is enclosed by these multiple layers of capsule. It looks like a cut onion on cross section. This is the Pacinian corpuscle. And Pacinian corpuscle, this is a receptor for fast vibration up to 800 cycles per second and for deep pressure, a question which has been asked. Where are these Pacinian corpuscles located? They are located in joint capsules. And you can correlate with that, isn't it? If you remember your first year MBBS, you were taught to test for vibration. How did you test for vibration? You took a tuning fork, 128 hertz, and you strike it and then you place it on bony prominences, because Pacin and corpuscles are present in the joint capsules. They are also present deep in the skin, fasciae and the muscle, which is the nerve fiber associated A beta. A beta is the nerve fiber which is associated with the Pacinian corpuscle. Remember, Pacinian corpuscle for fast vibration and for deep pressure. Then you have the Meissner's corpuscle. Now, Meissner's corpuscle, this is an elongated encapsulated receptor. This is elongated encapsulated receptor, and this is present in the dermal pegs of glabrous skin. What is glabrous skin? Glabrous skin is non-hairy skin, skin which is present on the palms, on the soles, lips. These are your glabrous skin, non-hairy skin. So remember, Meissner's is present in the dermal pegs. It's in the dermis. It's an elongated encapsulated receptor. And what is the Meissner's corpuscle meant for? Now, again, very, very important points. Nerve fiber associated A beta. It is present in glabrous skin. This is a receptor for fine, well-localized touch. Now, please remember, well-localized touch is also known as discriminative touch. So, if the question says discriminative touch, go for Meissner's corpuscle. Now, what is therefore a non-discriminative touch? Non-discriminative touch is crude touch. That is crude touch. But discriminative touch is fine touch. Now, this is different from two-point discrimination. For two-point discrimination, your better answer would be Merkel's discs, not Meissner's corpuscles. So once again, when it comes to discriminative touch, if the question says discriminative touch, your answer should be Meissner's corpuscle. If it says two-point discrimination, then your better answer is Merkel's discs. And what is non-discriminative touch? That is your crude touch, which is carried by the spinothalamic tracts. So this is also meant for slow vibration, texture, topognosis and braille. What is braille? Braille is that special script for the visually challenged. So this is as far as your the Meissner's corpuscle is concerned. Important points: nerve fiber A beta. Where do you find the Meissner's corpuscles? Glabrous skin, and especially they are very abundant in fingertips. 60% of the receptors on the fingertips are Meissner's corpuscles. Lips, nipples, these are the areas where these are specially abundant. All right. Okay, Chandrayan 1, I'm glad you're enjoying the session. Okay, let's go on to the next one. Slowly adapting receptors like Merkel's discs. Merkel's disc is also meant for fine touch, well-localized touch, and for sustained pressure. Like I said, if the question says two-point discrimination, better answer Merkel's. But discriminative touch, better answer Meissner's. For texture, better answer Meissner's. Topognosis also, better answer will be Meissner's. Ruffini's is found in the dermis of hairy and glabrous skin. This is for skin stretch, fluttering, vibration. Muscle spindle. Muscle spindle is a very important receptor because this is the only receptor which has got sensory fibers and it has got motor fibers. All receptors have only a sensory supply. Receptors are part of the sensory nervous system, but spindle has got both sensory as well as motor supply. The muscle spindle has got fibers inside which are known as the intrafusal muscle fibers. Intra, inside, and fusal, spindle. These are two types, nuclear bag and nuclear chain. Nuclear bag are about 2 to 3, nuclear chain are about 4 to 5, total number of intrafusal muscle fibers are about 5 to 6. Nuclear bag is of two types. There is nuclear bag dynamic and nuclear bag static. Nuclear chain is only for a static response. Now, what is a dynamic response? Dynamic means for rate of change of muscle length. Remember, muscle spindle is a receptor for muscle length, but dynamic, nuclear bag dynamic is meant for rate of change of muscle length. What do you mean by rate of change of muscle length? See, I'm doing a flexion extension, right? This is a rapid flexion extension and a slow flexion extension of these. So there is a difference in the rate of change of muscle length. That is by the nuclear bag dynamic. And what is static length? Static is the steady length. Static is the steady length. When this elbow is extended, this is a static length. So for dynamic response, nuclear bag dynamic. For static response, nuclear bag static and nuclear chain. So if I can make this over here, a little table for dynamic response, only nuclear bag. For static response, it is nuclear bag plus nuclear chain, which are the afferent or the sensory fibers. For the dynamic response, only 1A. For static response, 1A and 2, which is the motor to the muscle spindle. To nuclear bag dynamic is A gamma dynamic. For nuclear bag static is A gamma static. Please remember, A gamma fibers do not supply the complete intrafusal muscle fiber. They supply only the ends of the intrafusal muscle fiber, because only the ends have got actin myosin. Only the ends of the intrafusal muscle fibers are contractile. So this is the intrafusal muscle fibers, right? Again, once again, for dynamic response, only nuclear bag. For static, nuclear bag and nuclear chain. Sensory fibers for dynamic response, only 1A. For static response, 1A and 2. For motor fibers to the nuclear bag dynamic is A gamma dynamic. To nuclear bag static and nuclear chain is A gamma static. Right. Let's see the ascending tracts. Ascending tracts can be divided into posterior column, spinothalamic tracts and the spinocerebellar tracts. Absolutely right. S. A alpha is to the extrafusal muscle fibers. Two very important questions. Motor supply to intrafusal muscle fiber is A gamma. Motor supply to the extrafusal muscle fiber is A alpha. Excellent, S. I wish I knew your full name, S, but S will do. So excellent. Very good. All right, now let's see posterior column, spinothalamic tracts and spinocerebellar tracts. These are three major groups of ascending tracts. Spinocerebellar is meant for unconscious proprioception, and from the lower limb, you've got the dorsal spinocerebellar tract and the ventral spinocerebellar tract. From the upper limb, cuniocerebellar and the rostral spinocerebellar. Now, dorsal spinocerebellar is from the muscle spindle mainly, and also from the Golgi tendon organ. The ventral spinocerebellar is only from the Golgi tendon organ of the lower limbs. Upper limb cuniocerebellar will carry impulses from muscle spindle mainly, and also the Golgi tendon organ. Rostral spinocerebellar will carry impulses from the Golgi tendon organ of the upper limb, right? So these are your, and you have to remember that all the spinocerebellar tracts end on the same side cerebellar hemisphere. Posterior column spinothalamic tract will cross to the opposite side cerebral hemisphere, but the spinocerebellar tracts end on the same side cerebellar hemisphere. So let's see what is the posterior column meant for. Posterior column is meant for fine discriminative touch, localization, two-point discrimination, vibration, conscious proprioception, stereognosis, and the ability to judge the different degrees of pressure. What is stereognosis? If you remember, we asked the patient to close his eyes and then you place a familiar object in his hands and he feels it and tells you what that object is. That is stereognosis. That is carried by the posterior column. Spinothalamic tract, the lateral spinothalamic tract is pain and temperature, anterior spinothalamic tract, crude touch, itch, tickle, sexual sensations, and barogonosis. Two important questions. If there is a posterior column lesion, what will happen to barogonosis? Present or absent? Barogonosis will be present because that is carried by the anterior spinothalamic. Posterior column carries ability to judge the different degrees of pressure, but detection of pressure is by the anterior spinothalamic tract. Graph aesthesia. What is graph aesthesia? Graph aesthesia is you take the forearm of the patient, ask him to close his eyes, and you use the pen, the blunt side of a pen, and you write something. And you ask him to identify that. That is graph aesthesia. Graph aesthesia will be absent. For graph aesthesia, you need localization. Localization is a function of posterior column. Right? So this is one question. Second is the tract which is specific for stereognosis. This is specific for stereognosis. Is it going to be fasciculus gracilis or fasciculus cuneatus? Posterior column, you have two, fasciculus gracilis and fasciculus cuneatus. Fasciculus cuneatus, C for cuneatus, C for cervical. It carries fibers from the thoracic and the cervical region. Fasciculus gracilis from sacral and lumbar. So the tract which is specific for stereognosis is going to be fasciculus cuneatus. You are using your hands for stereognosis, and hands means thoracic and cervical fibers. So fasciculus cuneatus. So important questions regarding the tracts. Let's have a look at the stretch reflex. Let's have a look at the stretch reflex. Stretch reflex, like the knee jerk, the ankle jerk, the biceps jerk, brachioradialis, these are your deep tendon jerks, also known as myotactic reflex. This is a monosynaptic reflex. So for example, when you tap on the quadriceps tendon, you are increasing the muscle length. The receptor which is activated is the muscle spindle. The sensory fibers from the muscle spindle are 1A and 2. They enter into the spinal cord. They directly synapse with the A alpha motor neuron, which goes to the same muscle, to the quadriceps muscle. And again, as you had correctly pointed out, A alpha goes to the extrafusal muscle fibers, which are responsible for muscle contraction. So if the A alpha muscle fiber is stimulated, the muscle contracts and quadriceps will contract, and there is extension of the knee, the leg moves forward. The response is a muscle contraction and the number of synapses is 1. This is a monosynaptic reflex. Once again, stimulus for the stretch reflex, increase in muscle length or stretch. Receptor, muscle spindle. Sensory fibers, 1A and 2. Center, spinal cord. Efferent of the stretch reflex is A alpha. Please remember, try and remember this very, very carefully. Efferent of the stretch reflex, motor arm of the stretch reflex is A alpha, which goes to the extrafusal muscle fibers. Response is a muscle contraction, and the number of synapses that you can see over here is 1. It is a monosynaptic reflex. Golgi tendon organ is a bisynaptic reflex. Let's see this now. Inverse stretch reflex or the autogenic inhibition, this is a bisynaptic reflex. Again, let's see. Here what happens? Stimulus is an increase in muscle tension. Receptor is the Golgi tendon organ which is present in the tendons. The sensory is 1B 1B. Center is again the spinal cord, but here what has happened is the 1B fiber will excite an inhibitory interneuron, which will inhibit the A alpha motor neuron to that same muscle. So response will be a muscle relaxation. Number of synapses? 2. It is a bisynaptic reflex. Once again, stimulus, increase in muscle tension. Receptor, Golgi tendon organ. Sensory fibers, 1B. Center, spinal cord. Efferent or motor fibers, A alpha. Response is a muscle relaxation. That is why it's called a inverse stretch reflex. It is inverse to the stretch reflex. And number of synapses is 2. This is a bisynaptic reflex. Both the stretch reflex and the inverse stretch reflex are spinal reflexes. The center is the spinal cord. Great, let's go on to the descending tracts. Descending tracts or the motor pathways can be divided into medial and the lateral descending tracts. Lateral descending tracts, these are meant for distal muscles. These are meant for fine, skilled movements. There are 2 lateral descending tracts, the lateral corticospinal tract, or also known as the pyramidal tract. This is the major tract which is meant for fine skilled movement, and the rubrospinal tract from the red nucleus of the midbrain to the spinal cord. This is also known as the alternate pathway. But which is a major tract which is responsible for fine skilled movement? It is the pyramidal tract. There was a question which has been asked, which extrapyramidal tract functions like the pyramidal tract? And your answer is rubrospinal. This is the alternate pathway, but the major tract controlling fine skilled movement is the lateral corticospinal tract. Medial descending tracts are anterior corticospinal, vestibulospinal, tectospinal and reticulospinal. Remember, medial descending tracts are meant for axial muscles. These are meant for tone and posture. Anterior corticospinal, vestibulospinal, tectospinal will supply the A alpha, especially of the lower limb extensors. Lower limb extensors are primarily involved in erect posture, extensors of the hip, extensors of the knee. So these 3 tracts will supply the A alpha of the lower limb extensors. Reticulospinal tract, pontine will excite the A gamma of the lower limb extensors. It is an excitatory tract, and the medullary tract or the inhibitory tract will decrease the A gamma activity. So once again, lateral descending tracts for fine skilled movement, they supply the distal muscles. 2 lateral descending tracts, lateral corticospinal or the pyramidal tract and the rubrospinal. Medial descending tracts will supply the axial muscles. These are for tone and posture. Which are the medial descending tracts? Anterior corticospinal, vestibulospinal, tectospinal and the reticulospinal. Out of these medial descending tracts, which supplies the A gamma? That is the reticulospinal. Pontine reticulospinal is excitatory, medullary reticulospinal is inhibitory. Reticulospinal is the supraspinal control of muscle tone. A gamma activity controls muscle tone, and the tracts controlling A gamma activity and therefore muscle tone are the reticulospinal tracts. Great, let's go on to the cerebellum. Now, cerebellum is again a frequently asked topic in the INI-CET exam, and remember, cerebellum has got 3 parts. 4 pairs of deep nuclei and 5 cells. which are the three parts of the cerebellum. The first one is the vestibulocerebellum. This is involved in balance and eye movements. Vestibulocerebellum. The spinocerebellum is involved in motor coordination, and the cerebrocerebellum is involved in motor planning. So again, three parts: vestibulocerebellum or the flocculonodular lobe, balance and eye movements. Two important signs of cerebellar disease: ataxia and nystagmus. Spinocerebellum is involved in motor coordination. Sign of cerebellar disease: dysdiadochokinesia. And the cerebrocerebellum is involved in motor planning. So these are the three parts. You've been asked this question: what is the function of the vestibulocerebellum? And your answer is balance and eye movements. There are four pairs of deep nuclei. Which are the four pairs of deep nuclei? The vestibulocerebellum does not have any deep nucleus associated with it, because it has got direct to and fro connections with the vestibular nuclei in the medulla. Spinocerebellum, which is involved in coordination, there are three deep nuclei: fastigial for coordination of axial muscles, globose and emboliformis for control and coordination of distal muscles. Dentate is involved in motor planning. So which are the four pairs of deep nuclei? One for either side: fastigial, globose, emboliformis, dentate. Fastigial for control and coordination of axial muscles, globose and emboliformis for control and coordination of distal muscles, and dentate is for motor planning. And what is the organization? Mnemonic: doctors eat good food, right? What is doctors from lateral to medial? Doctors, D, dentate, eat, emboliformis, good, G, globose, F, fastigial, lateral to medial. Doctors eat good food, but doctors do not eat good food actually. We all survive on Maggie. Yes, Shovik, you're absolutely right. D, E, G, F. Doctors eat good food. So three parts: vestibulocerebellum, spinocerebellum, cerebrocerebellum, four pairs of deep nuclei: fastigial, globose, emboliformis, and dentate. And five cells. Which are the five cells of the cerebellum? Granule cells, basket cells, stellate cells, Golgi cells, and the Purkinje cells. The only excitatory neuron of the cerebellum is the granule cell. All the others are inhibitory. So again, easy question: glutamate secreting neuron. Glutamate is an excitatory neurotransmitter of the cerebellum is granule cell. It is excitatory. All others are inhibitory. Output of the cerebellar cortex. What is the cerebellar cortex? It is the outer layer of the cerebellum, is the Purkinje cell. And output of the deep nuclei, output of the cerebellum is from the deep nuclei. The connections of the cerebellum to other parts of the brain and the spinal cord is from the deep nuclei. This is an excitatory output. But the Purkinje cells modify the excitatory output of the deep nuclei. Now, this is a question which has been asked again and again in the INI-CET exam. Purkinje cells project to, and the answer is deep nuclei. What is the output of the cerebellum from? Output of the cerebellum is from the deep nuclei, which is an excitatory output. Purkinje cell project to the deep nuclei and modify this excitatory output of the deep nuclei. Input into the cerebellum is from the climbing fibers and mossy fibers. More important are the climbing fibers. They are formed by fibers of only one tract. They are formed by fibers of the olivocerebellar tract, from the inferior olivary nucleus to the cerebellum. Olivocerebellar tract. All other tracts entering the cerebellum will form the mossy fibers. Right, so this is your, if you can see this, a histology slide. There is a molecular layer which has got stellate cells and basket cells. Stellate cells are the most superficial. Then second layer is the Purkinje cell layer, which has the Purkinje cells, and granule cells and Golgi cells are the granular layer. And Purkinje cells will project to the deep nuclei. Again, a question which has been asked again and again. Okay. Let's see hypothalamus. Hypothalamic nuclei, again a favorite topic. For hunger, thirst, rage, aggression, this is the lateral hypothalamus. For satiety and reward, the ventromedial hypothalamus. Lateral hypothalamus is the hunger center, rage center. It is responsible for the aggression and it's also the thirst center. Ventromedial hypothalamus is the satiety or the reward center. Heat gain center. Heat gain center is the posterior hypothalamus. Heat loss center is the anterior hypothalamus. In summers, we need to lose heat. So you need the AC. So AC in summers, anterior hypothalamus is active in summers. This is your heat loss center. Posterior hypothalamus is your heat gain center, which is active in winters. For circadian rhythm, a question which has been asked, suprachiasmatic nucleus. For sexual activity, anterior-most and the posterior-most portions of hypothalamus. For neurosecretion, supraoptic nucleus, for secretion of ADH, and paraventricular nucleus for secretion of oxytocin. So ADH mainly by supraoptic and oxytocin mainly by paraventricular. This question has also been asked, which of the following hormones undergoes a neurosecretion? ADH and oxytocin undergo a neurosecretion. They are synthesized in the hypothalamus, transported into the posterior pituitary and released into the circulation from the posterior pituitary. So this is what is known as neurosecretion. Now a very interesting point here, and this is a question which has been asked. What was the ventromedial nucleus? Ventromedial nucleus of the hypothalamus is the satiety center. So if there is a bilateral lesion of the satiety center of the ventromedial nucleus, what is going to happen to the patient? In patient, if there's a lesion of the satiety center, he will never be satiated. So what happens? He has excessive eating, rage, aggression, right? So he has hyperphagia and rage. This motility is because of a bilateral lesion of the lateral hypothalamus. Rage, this is the, bilateral lesion of the ventromedial hypothalamus. So you have this motility. Whereas lateral hypothalamus, which is your hunger center, a bilateral lesion of the hunger center, that means there is no hunger here. So here you have an anorexic animal. So please remember the major functions. Lateral hypothalamus is the hunger center, thirst center, rage center. The ventromedial hypothalamus is your satiety center and the reward center. Right. Let's have a look at the posterior hypothalamus and anterior hypothalamus. Posterior hypothalamus is the heat gain center, active in winters. As you can see over here, winters you need to gain heat. So posterior hypothalamus. How does the posterior hypothalamus work? By increasing the sympathetic discharge, causing a peripheral vasoconstriction. Isn't it very common experience in winters? Your hands and feet are so cold because there is a peripheral vasoconstriction. Non-shivering thermogenesis and shivering. Major mechanism of heat gain in adults is shivering. In summers, when the outside temperature is high and you have gained heat, there is a need to lose that extra amount of heat, need to switch on your AC. Which is your AC? Anterior hypothalamus. And this causes a peripheral vasodilation and sweating. Major mechanism will be sweating. So posterior hypothalamus, heat gain center, anterior hypothalamus, heat loss center. Okay. Now again, this is a question which has been asked in the INI-CET exam. How is fever generated? Now you have to keep in mind there is a hypothalamic set point. Hypothalamus has a set point. It is a thermostat. Your body temperature will try to be at the hypothalamic set point. In normal individuals, the hypothalamic set point is at 37 degrees Celsius. So your body temperature is also at 37 degrees Celsius. But what happens in fever? Now, the first event which is going to happen is an elevation of the hypothalamic set point. Interleukin-1, which is secreted by the macrophages. This is the most important pyrogen. It causes elevation of the hypothalamic set point. And if there's an elevation of the hypothalamic set point, your body, let's say, hypothalamic set point has gone to 40. You are at 37 degrees Celsius. So which hypothalamic center will be activated? Heat gain center. So the posterior hypothalamus will now cause peripheral vasoconstriction, non-shivering thermogenesis, but mainly shivering. And that causes your body temperature to increase to the elevated hypothalamic set point. So what is going to happen at stage 2? Mainly shivering. And this is a common experience whenever fever is rising, chills and rigors. Then stage 3. What happens in stage 3? Stage 3, there is now a lowering of the hypothalamic set point. Now, the body temperature is higher, hypothalamic set point is lower. Now the body has to lose heat so that the temperature can come to, can match the lowered hypothalamic set point. So what is going to happen at 4? Now the anterior hypothalamus will be activated, which is the heat loss center. And the major mechanism to be activated when you're losing heat or when the temperature is falling, sweating. And this is exactly the question which was asked. What happens in phase 2, shivering or sweating? And your answer is shivering, right? So please remember, body temperature will try to match the hypothalamic set point. In fever, the hypothalamic set point is first elevated, then the body temperature matches the elevated hypothalamic set point by generating heat, shivering. Then the hypothalamic set point is lowered. Then the body temperature also comes down. Major mechanism which causes lowering of body temperature is sweating. Common experience when the fever is rising, shivers, chills, rigors, and when the fever is falling, sweating. Absolutely right. Okay. Let's go on to the cardiac action potential. Now, cardiac action potential, also known as the plateau potential, this is seen in all parts of the heart except the SA node and the AV node. The plateau potential can be recorded in the myocardial cells. Resting membrane potential minus 90 millivolts. Phase 0 is depolarization phase. This is because of an increase in the sodium influx. Phase 1 is the early repolarization. This is because of closure of sodium channels and a decrease in sodium influx. Phase 2 is the plateau phase. And what happens in the plateau phase? Now there is opening of calcium channels. So there is influx of calcium and there is also an efflux of potassium. There is a calcium influx through slow calcium channels and a potassium efflux. There is gain of positive charge and loss of positive charge happening at the same time, and because of that the potential is it sort of reaches a plateau, which is called the plateau phase. At this arrow, the calcium channels close, and phase 3 is your late repolarization, which is only due to a potassium efflux. So these are your phases. The important question which is asked is that the plateau phase is due to what? Plateau phase is due to a calcium influx through slow calcium channels, or also known as slow sodium calcium channels, and a potassium efflux. And what is the advantage of plateau? Advantage of plateau is that the refractory period, it causes a prolonged absolute refractory period. And because of a prolonged absolute refractory period, heart muscle cannot be tetanized. We've spoken about tetanus in the case of skeletal muscle, physiological tetanus, but heart muscle cannot be tetanized because, like I said, it has a prolonged absolute refractory period. And what is responsible for that prolongation of the absolute refractory period? The plateau phase. And what is the plateau phase due to? Calcium influx through slow calcium channels. Pacemaker potential. Pacemaker potential is recorded from the SA node and the AV node, which is the normal pacemaker of the heart, SA node. Why is the SA node the normal pacemaker of the heart, even though any part of the heart, including the ventricular muscle, can become the pacemaker? The reason is highest rate of discharge. SA node has the highest rate of discharge. 3 phases, plateau potential had 5 phases, this has got 3 phases. Phase 0, phase 3 and phase 4. Phase 0 here is because of calcium influx through calcium L channels. It is not because of sodium, it is because of calcium. Phase 3 is because of a potassium efflux. This is the repolarization phase. Phase 4 is the pre-potential phase, and pre-potential phase is because of 3 reasons. Firstly, what is the pre-potential phase? In the pre-potential phase, there is a slow and spontaneous depolarization till the firing level. Slow and spontaneous depolarization till the firing level. That means to reach the firing level, the cell has to gain positive charge. And there are 3 mechanisms by which it gains positive charge. The first is there is a decrease in potassium efflux. Yes, opening of the F channel or the funny channel, also called the H channel. H stands for hyperpolarization. Funny channel, why is it called the funny channel? It is called the funny channel because it permits the movement of both sodium and potassium. But the movement of sodium predominates. That's why it's called the funny sodium channel. And calcium influx through the calcium T channel. 3 reasons for the phase 4. Number 1, decrease in potassium efflux. See, in phase 4, the cell has to gain positive charge. 3 mechanisms by which it is gaining positive charge. Number 1, by decreasing the outward movement of potassium. Number 2, by opening the funny channel through which the movement of sodium predominates. And number 3, by opening calcium T channels through which calcium will come from outside to inside. These 3 mechanisms will cause a net gain of positive charge, and the cell will go from resting membrane potential to firing level. Once it reaches firing level, the calcium L channels will open and there will be the depolarization, right? Okay, so Chandrayan 1 says what happens to the hyperpolarization phase is because of slow closure of potassium channels. But hyperpolarization in the plateau potential may not be recorded, right? But if it is present, it is because of slow closure of the potassium channels. Now, S says, what about the sodium-potassium pump? Now, you must understand, sodium-potassium pump has no role in the pre-potential phase, right? The sodium-potassium pump is, what is the role of sodium-potassium pump in an action potential? In a single action, after a single action potential, nothing, no role of the sodium potassium pump. But after a few thousand action potentials, there is a slight ionic imbalance which is restored by the sodium potassium pump. Please keep in mind that ionic changes during action potentials are very minute. They do not cause significant changes in concentration. Movement of just a few ions is sufficient to produce a change in potential. It's only after a few thousand action potentials that there is some ionic imbalance which is restored by the sodium potassium pump. But remember, after each action potential, there is no role of the sodium potassium pump. Is it okay, S? All right. A little bit about the hemodynamics. Ohm's law states that flow is equal to delta P by R. Flow is directly proportional to the pressure difference at the two ends of the tube. Delta P is P1 minus P2 and R is the resistance to flow. Second important law of hemodynamics is velocity is inverse to the total cross-sectional area. If you look at a single vessel, it divides into smaller vessels, the total cross-sectional area will increase. This is A2, this is A1. So remember, V1 into A1 is equal to V2 into A2. This is the third one. More the total cross-sectional area, less will be the velocity of flow. Like for instance, a larger artery breaks up into smaller arterioles and smaller arterioles and finally into capillaries. So the total cross-sectional area increases. So velocity of flow decreases. Less velocity in capillaries. Remember, it is the total cross-sectional area which is important. That means cross-sectional area of all the capillaries put together. Hagen-Poiseuille's law states that resistance is equal to 8 neta L over pi R4. 8 neta L over pi R4. Neta is viscosity, L is length and R is radius. So flow is equal to delta P by R, and if I substitute R over here, it becomes delta P into pi R to the power 4 divided by 8 neta L. So flow is equal to pi by 8 into delta P R to the power 4 divided by neta L. So flow is directly proportional to pressure difference, directly proportional to the fourth power of radius, inverse to the viscosity and inverse to the length. Laminar flow and turbulent flow is given by what is known as the Reynolds number. Reynolds number is rho dV by neta. Higher the Reynolds number, more the tendency for turbulence. Rho is density, d is diameter, v is velocity, neta is viscosity. Most important factor which determines a tendency for turbulence is velocity. More the velocity, more the turbulence. For example, at the root of aorta, flow is turbulent, velocity is very high, so flow is going to be turbulent. Laplace's law. Laplace's law is T is equal to P into R. T is the wall tension, P is the distending pressure, R is the radius. Right? When you look at a hollow viscous, P is the distending pressure, T is the wall tension. So T is equal to P into R. So S says, please explain resistance. What? Resistance wala concept in amputation. Okay, let me try and see that. If I can find a blank slide. Sorry, I'm not able to get a blank slide. See, what happens in a resistance is, see, when you look at the systemic circulation, sorry, I can't find a blank slide. Okay, let me try and see, when you look at the systemic circulation is divided into a number of parallel circuits. Have you understood? The aorta will divide into, what are parallel circuits? Matlab, the blood supply to the kidney, to the liver, to the limbs, to the intestine. These are parallel circuits. And what happens when anything is in parallel, the total resistance reduces. Have you understood? Systemic circulation is divided into a number of parallel circuits. All these, renal circulation, the splanchnic circulation, the blood flow to the limbs, these are parallel circuits. And total resistance decreases. So if I remove one parallel circuit, the resistance will increase. Have you understood? So an amputation, you're removing one circuit which was in parallel. So resistance, total peripheral resistance increases. So there is generally post-amputation, patients tend to have hypertension. Have you understood? Yes, is that okay? All right. So when you look at the cardiac cycle, now here you have the heart sounds, ECG, the aortic pressure changes, and the JVP changes with the cardiac cycle. Between the first and the second heart sound, you've got ventricular systole. Between the second heart sound and the next first heart sound is the ventricular diastole. Yes? S3 is in the first rapid filling phase. S4, if present, is due to atrial contraction in the second rapid filling phase. When you look at the ECG, you have to keep in mind ECG is electrical activity, graphical representation of the electrical activity. And always electrical activity is followed by mechanical. Contraction is mechanical. Now, if you look at the aortic pressure changes, this is the point where the aortic valve opens. When the aortic valve opens, then you have an increase in the aortic pressure to 120. Then where the aortic valve closes, you get what is known as the incisura or the dicrotic notch. And then the JVP. JVP has got 3 positive and 2 negative waves. A wave, atrial contraction, C wave due to bulging of the closed tricuspid valve into the right atrium during isovolumetric contraction. X descent, closed tricuspid valve is pulled downwards during ejection phase. V wave due to venous filling of the right atrium just before opening of the tricuspid valve, and Y descent is because of flow of blood from the right atrium into the right ventricle. And to remember this, see, in the exam you do not have time to remember the entire cardiac cycle. So there is a small little mnemonic for you to remember the sequence of events. PAQR 1CX T2V3. And somebody made a very interesting mnemonic for this. He said, पान की दुकान में QR code को scan किया, एक cigarette ली, chest x-ray कराया, and the finding is 2V3. This is the way to remember. So PAQR, पान की दुकान में QR कोड को स्कैन किया, एक सिगरेट ली, चेस्ट एक्सरे कराया, जिसकी फाइंडिंग है 2V3, right? So let's see this. P wave is the first event, that is atrial depolarization, followed by A wave of JVP, followed by Q wave of ECG, followed by R wave of ECG, followed by the first heart sound. Please remember, the first heart sound is just after the peak of R, a question which was asked in the INI-CET exam. PAQR1C. Then C wave in the isovolumetric contraction. I've already told you C wave is due to bulging of the closed tricuspid valve into the right atrium during isovolumetric contraction. 1CX. Then you have the T wave. After X, I'm sorry, I've forgotten over here, I should have added T. 1CX T2V3. So the chest X-ray finding is T2V3. T, then the second heart sound, followed by V, and then the third heart sound. V, third heart sound corresponds with the Y descent. Second heart sound corresponds with dicrotic notch. And fourth heart sound, if present, will coincide with the A wave. So पान की दुकान में QR कोड को स्कैन किया, एक सिगरेट ली, चेस्ट एक्सरे किया, and the finding is T2V3, not 2V3, T2V3. I forgot that. Okay. Thank you, Jai Shri Ram. I'm glad that you are enjoying this session. Hopefully you are enjoying the session. Okay. All right. Then the left ventricular pressure volume loop. Again, a question frequently asked. Here we have the left ventricular volume on the x-axis and the pressure on the y-axis. So at point A, what has happened? The left ventricular volume is at 120. The filling is complete. It is filled with blood. The pressure of the left ventricle is between 5 to 10 millimeters of mercury, higher than the left atrial pressure. So at this point, the mitral valve closes. What is A? A is the end of the filling phase. Volume of the left ventricle is 120, pressure is approximately 5, higher than the left atrial pressure, mitral valve closes. A to B is the isovolumetric contraction phase. Left ventricle is a closed chamber, begins to contract. There is a sharp increase in volume with no change in pressure. At point B, the LV pressure exceeds the diastolic blood pressure of the aorta. So at point B, the aortic valve opens. B to C is the ejection phase. As soon as the aortic valve opens, blood will go from the ventricle to the aorta. So ejection phase. Pressure initially rises to 120 and then the LV pressure begins to fall. At point C, as soon as the LV pressure becomes lower than the aortic pressure, the aortic valve closes. Remember, mitral valve closes, produces the first heart sound, aortic valve closure produces the second heart sound. What do you have between S1 and S2 is the systole. Systole has got two phases, isovolumetric contraction and the ejection phase. At C, end of systole. Aortic valve is closed, mitral valve is not yet open. This is your isovolumetric relaxation phase. Sharp fall in pressure with no change in volume. It reaches point D. As soon as the LV pressure becomes lower than the left atrial pressure, the mitral valve opens at point D and you get the filling phase. So A to B isovolumetric contraction, B to C ejection phase, C to D isovolumetric relaxation, D to A is the filling phase. At A, mitral valve closes, at B, aortic valve opens, at C, aortic valve closes, at D, mitral valve opens. Between A to C is systole, C to A is diastole. So remember what all questions have been asked from here. The first one was which point coincides with the diastolic blood pressure, and the answer was B. Highest point of this loop will coincide with the systolic blood pressure. So the difference between systolic and diastolic is the pulse pressure. Width of the loop is equal to the stroke volume. I can calculate ejection fraction from here. Ejection, what is ejection fraction? This is stroke volume divided by end diastolic volume. How do I get the stroke volume? Width of the loop. How do I get the end diastolic volume? From point A. That is the end of this diastole. The volume at point A is the end diastolic volume. So I can calculate the ejection fraction. And how much is the normal ejection fraction? 0.55 to 0.65, 55 to 65%. Now to remember which valve opens and closes at which point, you have to remember your physiology man. So man, Coco. At point A, mitral valve closes. At point B, aortic valve opens. At point C, aortic valve closes. And at point D, mitral valve opens. At point A, first heart sound. At point C, second heart sound. But for this, you have to remember where is A, B, C, D. If you forget that, then everything will go for a toss. Normally, opening of a valve does not produce a sound. But if the aortic valve is stenosed, you will hear an ejection click. Ejection click is after the first heart sound. It's a systolic sound. If mitral valve is stenosed, then you hear an opening snap. And when do you hear an opening snap? After the second heart sound. Is that clear? Okay. So, ma'am, Coco. All right. So, I'm glad Chandrayan 1, you are enjoying this session. Yes. Now, these are the flow volume curves in valvular conditions, flow volume loops in, pressure volume loops in valvular conditions. So, what will happen in stenotic lesions? In stenotic lesions, the stroke volume will be reduced. And in regurgitant lesions, the stroke volume, which is the width of the loop, this will be increased. Right? So, here the first one is a tall loop. So, a tall and a narrow loop. This is typically seen in aortic stenosis. Why a tall loop? Because now the aortic valve is stenosed. So, the left ventricle has to exert more pressure to open a stenotic valve, and stroke volume will be reduced. So, tall and narrow loop in aortic stenosis. In mitral stenosis, the loop shifts to the left. Why does it shift to the left? Because there is a decrease in the end diastolic volume of the left ventricle. Why is a decrease in the end diastolic volume of the left ventricle? Because now the mitral valve is stenosed. So, filling of the left ventricle will be incomplete. So, end diastolic volume of the left ventricle will be reduced and the loop shifts to the left. Okay with that? Now, let us see the two regurgitant lesions. Now, which is AR and which is MR. Now, this is AR here. Why so? Because you have to look at the isovolumetric relaxation phase. See, if I'm showing you the left side of heart only, okay. Now, during isovolumetric relaxation, both aortic and the mitral valves should be closed. But in this case, the aortic valve is regurgitant, incompetent. It is not closing properly. So, what will happen in isovolumetric relaxation? Normally, there should be no change in volume. But here now there is regurgitation of blood into the left ventricle. So, the left ventricle volume will increase in the isovolumetric relaxation. So, this you can see in this graph, there is an increase in the LV volume. It's not a straight line, isovolumetric relaxation, it is tilting to the right side in isovolumetric relaxation. Then obviously this becomes MR, because what happens in MR? Now the mitral valve is incompetent. Normally both the valves should be closed, but now the mitral valve is incompetent. So what do we find? Initially, as the ventricle relaxes, ventricular pressure is still higher than the atrial pressure. So some blood will go towards the left atrium. Left ventricular volume will reduce, and then this blood will regurgitate back into the left ventricle, and the left ventricle volume will increase. So you get first a decrease in volume and then an increase in the LV volume. All right, Rahul Jimbal, I'm so glad that you have been able to understand this. Yes, so simple, this is your tall and narrow loop, AS. Loop shifts to the left, MS. Please remember, narrower loops are stenotic lesions, wide loops are regurgitant lesions. In AR, isovolumetric relaxation, there is increase in the LV volume. In MR, in isovolumetric relaxation, initially there is a decrease in LV volume because the LV blood will go towards the left atrium. Then the left atrial blood will go back into the left ventricle, followed by an increase in the LV volume in the isovolumetric relaxation phase. Great. Important definitions: cardiac output. Cardiac output is the volume of blood ejected per ventricle per minute. So when I say cardiac output is equal to left ventricular output, which is equal to the right ventricular output. But actually speaking, the left ventricular output is 1 to 2% more than the right ventricular output. If any one of you who's attending the session can tell me why is the left ventricular output 1 to 2% slightly more than the right ventricular output, I will give you a chocolate. Yes, S says awesome. Okay, great. I'm so glad that I'm able to sort out your confusions. Yes. All right. So if somebody can tell me why is, practically speaking, LV output is equal to right ventricular output. When I say cardiac output is 5 liters per minute, LV output is 5 liters, RV output is also 5 liters per minute. But theoretically, LV output is 1 to 2% more than the right ventricular output. If someone can tell me why, I will be no. It is not because of the pressure. Anything else? Rahul Jimwal, Subhash, Chandrayan? Yes? I'll wait. Let me see if somebody can tell me. Muscle mass high, no Shovik. Have you heard about physiological shunting? No, not because of physiological shunting. What is physiological shunting? A small part of the venous blood from the coronary, from the bronchial circulation, drains directly into the left atrium. That is called physiological shunting. So I keep the chocolate for myself. Okay, great. Okay, so this is physiological shunting. Yes, this is anatomic anomaly. Each one of us has this. A small fraction of venous blood from the coronary, from the bronchial circulation, drains directly into the left atrium. Next important definition, cardiac index is cardiac output per meter squared of body surface area. Normal cardiac index is 3.2 liters per minute per meter squared of body surface area. Cardiac output is heart rate into stroke volume. Cardiac output can also be written as mean arterial pressure over the total peripheral resistance. For regulation of cardiac output, anything which affects the heart rate and factors affecting stroke volume. Myocardial contractility. What can affect the stroke volume? Myocardial contractility. If the ventricles start pumping blood with more force, like for example, when there is sympathetic discharge which is positive inotropic, or if I use inotropic drugs, or if I increase the venous return. We've discussed that, Frank-Starling's law. More the venous return, more will be the end diastolic volume, more will be the initial length, more will be the tension generated, more will be the stroke volume, more will be the cardiac output, right? So this is regulation of cardiac output. All right. Measurement of cardiac output has been asked a few years back, not very recently. Non-invasive echocardiography and Doppler studies. Invasive, there are 3 techniques: dye dilution technique, thermodilution technique, which uses the Swan-Ganz catheter, and cardiac output by the Fick's principle, which says cardiac output is oxygen consumption in ml per minute divided by arteriovenous oxygen difference in ml per liter. Yes, so S says, due to coronaries, there will be more end diastolic volume in the left ventricle. No, yes, but please remember, only a part of the coronary blood. Small part of the coronary blood, small part of the bronchial circulation, venous blood. this drains directly into the left atrium and therefore into the left ventricle. Have you understood? So there will be more filling of the left ventricle, which causes more force of contraction, therefore more left ventricular output, 1 to 2% more. Have you understood? Is that clear? It's only a small part of the coronary and the bronchial circulation, which is called physiological shunting. Okay? See, venous blood has no business coming to the left side of heart. Venous blood should all go to the right side of heart. But because of this anatomic anomaly, a small percentage of blood comes to the left side. Right? Okay. Blood pressure. What is systolic blood pressure? Maximum pressure during systole, diastolic blood pressure, minimum pressure during diastole. What is pulse pressure? This is the systolic minus diastolic, and remember, pulse pressure is directly proportional to the stroke volume and inverse to the arterial compliance. Again, a question which has been asked. And what is mean arterial pressure? This is diastolic blood pressure plus 1/3 of the pulse pressure. So important definitions over here. Now, this is also the Frank-Starling's law. Preload is the same thing as the end diastolic volume. More the preload, more will be the stroke volume. More the preload, more the initial length of the ventricular muscle fiber, more will be the tension generated, more will be the stroke volume, but up to a physiological limit. So this is your Frank-Starling's law, which has been asked last time. If I increase the cardiac function by giving positive inotropic agents or by increasing the sympathetic discharge, the graph will shift upwards. And if I reduce the cardiac function, for example, let's say in a patient of cardiac failure, the graph shifts downwards. All right. Mary's law. Mary's law states that heart rate is inverse to the blood pressure. More the blood pressure, less the heart rate. Less the blood pressure, more the heart rate. A patient who has lost blood, hemorrhage, there is a hypotension plus a tachycardia. A patient who has road traffic accident, lost blood, he comes to you in the emergency, he has low blood pressure, but a tachycardia is associated with it. Bainbridge reflex says sudden increase in blood volume increases the heart rate. Please remember, when there is a sudden increase in blood volume, it stimulates what is known as the atrial stretch receptors. And these decrease, they inhibit the vagal action on the SA node. And that in turn increases the heart rate. So Mary's law and Bainbridge reflex. Bejold-Jarisch reflex, again a question which has been asked. Injection, this was asked, injection of which of the following substances will stimulate this reflex? That is serotonin, capsaicin, phenylbiguanides and veratridine. So S says reflex tachycardia due to, let's say, hypotension, due to antihypertensive drugs? Yes. Okay, I'll tell you about Cushing's also. So injection of following substances into the coronary: serotonin, capsaicin, phenylbiguanides, veratridine. Response is hypotension, bradycardia, apnea followed by rapid shallow breathing. Where are the receptors located? These can be chemosensitive vagal C fibers in the cardiopulmonary area, juxtacapillary region, ventricles, atria and the pulmonary artery. Right? So this is your Bejold-Jarisch reflex. This is also called the coronary chemo reflex. Now, what is the Cushing's reflex? So Cushing's reflex is whenever there is a raised ICP, intracranial pressure. This could be because of an intracranial bleed, maybe head injury, cerebral hemorrhage. Raised intracranial pressure it compresses the cerebral blood vessels. This causes CNS ischemia. And once there is a CNS ischemia, it causes what is known as the CNS ischemic response. And this results in a sharp increase in the sympathetic discharge. If there is a sharp increase in the sympathetic discharge, it increases the blood pressure. But because of baroreceptors, what happens when when blood pressure increases, baroreceptors are stimulated. Baroreceptors will reduce the sympathetic. Baroreceptors will reduce the sympathetic, increase the parasympathetic response, and that causes what is known as a reflex bradycardia. So importantly, this is what you do, isn't it? When you are let's say in the emergency and you have a patient of head injury, the first thing that you do is see his pulse rate. If there is a bradycardia, that means this patient has got a raised ICP. That is your Cushing's reflex. Cushing's triad is increase in blood pressure, bradycardia, and irregular respiration. Right? So that is yes, absolutely right. To increase the cerebral perfusion pressure, there will be an increase in the sympathetic discharge, which is also called the CNS ischemic response. But when the blood pressure increases, the baroreceptors will immediately decrease the sympathetic and increase the parasympathetic. And they cause a reflex bradycardia. Is that clear? Okay. Now, blood pressure and heart rate changes during a Valsalva. Now, what is Valsalva? Valsalva is a forced expiration against a closed glottis. Forced expiration against a closed glottis. That is a Valsalva. Forced expiration against a closed glottis. And when do you do a forced expiration against a closed glottis? For example, any type of straining, even when you're straining to pass stools, or when a lady is in labor, she's doing a Valsalva, right? That is forced expiration against a closed glottis. Now, what happens to the blood pressure and heart rate during a Valsalva? So, as you can see over here, this is the blood pressure and this is the heart rate. If the blood pressure increases, heart rate reduces. If blood pressure falls, heart rate increases. Mary's law. Okay? Now, phase 1. In phase 1, we find that there is an increase in blood pressure. Why is there an increase in blood pressure? Because please remember, when you're doing a Valsalva, there is increase in the intrathoracic pressure, which is added to the aortic pressure. In phase 2, please remember, intrathoracic is also known as the intrapleural pressure or the pleural pressure. Normally, this pressure is negative. But when you do a Valsalva, this pressure becomes positive. So first, when you start doing a Valsalva, what is Valsalva? Like I said, when you're doing a straining, right? You're doing a forced expiration against a closed glottis. Initially, there is going to be an increase in pressure because the intrathoracic pressure, which has become positive, it is added to the aortic pressure. Then in phase 2, because the intrathoracic pressure has become positive, the venous return and the cardiac output start decreasing. So there is a fall in the pressure. This is phase 2. In phase 3, when you stop the Valsalva, so opposite of phase 1, and in phase 4, the intrathoracic pressure is normal, cardiac output is restored, but the peripheral vessels are still constricted, so BP rises. Let's see this once again. In phase 1, there is an increase in blood pressure. Why? Because the positive intrathoracic pressure is added to the blood pressure. So increase in blood pressure and a decrease in heart rate. Then in phase 2, the high intrathoracic pressure starts compressing the veins. It starts reducing the venous return and cardiac output, and the blood pressure begins to fall. There is a decrease in blood pressure. If there is a decrease in blood pressure, the baroreceptors will increase the sympathetic discharge, and you will get will increase the sympathetic discharge. So heart rate begins to increase. As you can see over here, heart rate increases. There's a fall in blood pressure, but the heart rate increases. So during a Valsalva, you will get a tachycardia. Then the moment you stop the Valsalva, reverse of phase 1. But in phase 4, you continue to, you get an increase in pressure, because remember, during a Valsalva, the sympathetic discharge had increased. So peripheral blood vessels are constricted and blood pressure increases, heart rate decreases. Once again, during a Valsalva, there is a tachycardia. After a Valsalva, there will be a decrease in heart rate. Is that clear? Phase 1, increase in intrathoracic pressure added to the aortic pressure, blood pressure rises. Phase 2, but this is transient, this is very small increase in blood pressure. But phase 2, which is more prominent, there is decrease in venous return, decreased cardiac output, decrease in blood pressure associated with increase in heart rate. Phase 3, opposite of phase 1, again very short phase, but in phase 4, there is an increase in blood pressure. Why? Because the peripheral blood vessels are still constricted. And what will happen to heart rate? Heart rate decreases. See, phase 3 is simply opposite of phase 1. In phase 1, the moment you start the Valsalva, intrathoracic pressure, which has become positive, it is added to the aortic pressure. When you stop the Valsalva, intrathoracic pressure becomes negative, so it is subtracted from the aortic pressure, so the blood pressure falls. Is it okay, S? Okay? Phase 3 is opposite of phase 1. Phase 4, you have a sustained increase in pressure because the blood vessels are constricted and heart rate begins to fall. See, heart rate changes are more easily seen because heart rate is controlled both by sympathetic and parasympathetic. Okay? Can I move on? Yes? Regional blood flow changes in various vascular beds during exercise. Now, this is again an important question. As you can see over here, when you are exercising, the blood flow to the skeletal muscles has to increase. There is increased flow to the heart, right? But what will happen to blood flow to the splanchnic circulation, to the kidneys, to the bone marrow? This is going to reduce. There is a redistribution of blood flow during exercise. And what is this redistribution? The blood flow to the splanchnic circulation, to the kidneys, to the bone marrow will reduce, but blood flow to the heart and the skeletal muscles show a huge increase in blood flow. To the brain, the blood flow remains unchanged. To the skin, yes, to the skin also there will be initially a decrease and then an increase. As the temperature rises, when you're exercising, there is increased blood flow to the skin as well. So this is a question which has been asked, blood flow to which organ remains unchanged? And your answer is brain. Skeletal muscle blood flow at rest is just 3 to 4 ml per minute per 100 gram of tissue, and during exercise, because primarily due to increase in local metabolites. Locally in the muscles, there is release of local metabolites. This blood flow increases to 70 to 80 ml per minute per 100 gram of tissue. A huge increase in the cerebral blood, in the skeletal muscle blood flow. Aadha ghanta aur. Okay. What are the cardiovascular changes during isotonic exercise? So let's see this. Whenever you begin to exercise, there is going to be an increase in sympathetic discharge. What is the main reason for increase in sympathetic discharge? This is due to the joint proprioceptor stimulation. Before you increase exercise, it is because of a psychic influence, the feed-forward mechanism. But when you start right at the onset, because of when you're exercising, your joint proprioceptors are being stimulated, they will increase the sympathetic discharge. So joint proprioceptor stimulation. Yes, this is responsible for increase in sympathetic discharge. This increases heart rate, increases the force of contraction of the heart. It will cause a venoconstriction and decrease the venous compliance. What is compliance? Distensibility. Veins will be constricted and there is a venoconstriction. There will be a decrease in the venous compliance. And because there is a decrease in venous compliance, venous return will increase, stroke volume increases, cardiac output increases. During exercise, the cardiac output becomes 4 to 5 times the resting cardiac output in a normal individual. In an athlete, 6 to 7 times the resting cardiac output. Systolic blood pressure will increase. Total peripheral resistance reduces. There is at the level of, especially in the skeletal muscles, there is a dilation. Arteriolar dilation because of local metabolites, right? So total peripheral resistance, sorry, I should change this. Total peripheral resistance is maybe unchanged to decrease. It may be decreased or unchanged. See, I just spoke about redistribution of blood. So wherever the blood flow increases, the resistance in the vessels reduces. Where the blood flow is reduced, resistance has increased. So some areas there is reduced blood flow, some areas there is increased blood flow. So total peripheral resistance either will show a slight decrease or may remain unchanged. So similarly, DBP will be unchanged or slight decrease. MAP is more or less remains the same. But what will happen to pulse pressure? Pulse pressure definitely increases. Pulse pressure increases. MAP nearly unchanged, because remember, MAP is DBP plus 1/3 of pulse pressure. Yes, so it is closer to the DBP. DBP is unchanged or slight decrease, and MAP is also more or less unchanged. Okay. What happens during isometric exercise? In isometric exercise, there is an increase in the tension of the muscles, which starts compressing the blood vessels in the muscles. So sympathetic discharge will definitely increase because you're doing exercise. Heart rate increases, myocardial contractility increases, there is increase in stroke volume, increase in cardiac output, increase in SBP, but now the total peripheral resistance is increased. Why increased? Because the blood vessels in the muscles are being compressed. There is increase in tension in the muscles. There's an external compression of these blood vessels. So DBP increases, MAP increases, blood flow to the muscles reduces. So this is an important part that you have to remember, that here the total peripheral resistance will in fact increase. Right, spirometry. We must know the different lung volumes and capacities. What is tidal volume? Volume of blood, volume of air inspired or expired during a normal tidal respiration. What is IRV? Volume of air inspired forcefully over and above a tidal inspiration with maximum effort. What is ERV? Volume of air expired forcefully over and above a tidal expiration with maximum effort. What is residual volume? Volume of air which remains in the lungs at the end of a maximum expiration. What is inspiratory capacity? IRV plus tidal volume. What is expiratory capacity? ERV plus tidal volume. What is forced vital capacity? This is the volume of air expired forcefully after a forceful inspiration. And what is forced vital capacity? IRV plus tidal volume plus ERV. Add up all the lung volumes, you get total lung capacity. What is total lung capacity? This is IRV plus tidal volume plus ERV plus the residual volume. So these are, you should be absolutely clear about the lung volumes and capacities. These can be asked as a image-based question and you have to answer. You may be asked to identify one of these. So be very clear, what are the different lung volumes and capacities. Again, an important topic which has been asked, airway resistance. Now, airway resistance, when I measure the airway resistance, is it the maximum in the large-sized, medium-sized or the small-sized airways? Now, the airways, when you look at the tracheobronchial tree, it is divided into, it looks like a inverted tree. The trachea dividing into smaller and smaller airways, yes. First the major bronchi, then smaller bronchi and still smaller and so on and so forth. It looks like an inverted tree. So the tracheobronchial tree has been divided into 23 generations. Generation 0 is the trachea. Generation 1 to 16 is the conducting zone. 17 to 23 is the respiratory zone. And remember, which are the medium-sized airways? Medium-sized airways are 3rd to 5th generations, 3 to 5. Now, airway resistance is going to be maximum in the medium-sized airways, not the large, not the small-sized airways. And this question has been asked as an INI-CET exam. Is the airway resistance maximum in the trachea, in the bronchus, in the bronchiole or in the alveolar duct? And your answer, as you can see over here, is the bronchus. The medium-sized airways will show the maximum resistance to airflow. So this is an important question. And why do the medium-sized airways show you the maximum resistance to airflow? This is because the pattern of airflow in the medium-sized airways is turbulent. Turbulence produces increased resistance. Now, this is one table which you are very familiar with, what happens in obstructive and restrictive lung diseases. Obstructive lung diseases is bronchial asthma, bronchitis, COPD, emphysema, right? So these are examples of obstructive lung diseases. Restrictive lung diseases could be pulmonary causes like pulmonary fibrosis, pneumoconiosis, asbestosis, or extrapulmonary causes like kyphoscoliosis. So basically, obstructive lung disease, there is an obstruction to flow, and restrictive lung disease, a restriction in expansion. In obstructive lung diseases, the rates are affected more than the volumes. The first 3 parameters are the volumes: total lung capacity, residual volume, FVC. These are volumes. In obstructive lung disease, rates are affected more than the volumes. So what happens in obstructive lung disease? FEV1 by FVC ratio, this is reduced. PEFR is decreased, MEFR is markedly reduced. In restrictive lung diseases, volumes are affected more than the rates. Total lung capacity, residual volume, forced vital capacity is reduced in restrictive lung diseases. Rates are not as much affected. Right? So this is the basic difference between obstructive and restrictive lung diseases. In the flow volume curves, in obstructive lung disease, this is obstructive lung disease, which is if you can see this here, it is what is known as a scooped out curve. This is obstructive lung disease. In restrictive lung disease, it is a tall and narrow curve. This is a flow volume curve for a restrictive lung disease. Obstructive lung disease, scooped out curve. In restrictive lung disease, tall and a narrow curve. Then a box-like curve. This is box-like curve. This is seen in large airway obstruction. A large airway obstruction, like for instance because of a foreign body or because of a tumor. This produces a box-like curve. This is large airway obstruction, fixed type. A large airway obstruction, extrathoracic variable. What is extrathoracic? Extrathoracic variable means above the 6th tracheal ring. Where is the 6th tracheal ring? Angle of Louis. An extrathoracic variable obstruction, for example, vocal cord paralysis. Here, this is the graph which is going to be produced. Expiration is normal. Inspiratory curve is truncated. In intrathoracic variable, inspiration is normal, expiratory curve is flattened. So remember, E for extrathoracic, E for expiration is normal. In intrathoracic variable, I for intrathoracic, I for inspiration is normal. But in a large airway obstruction, fixed type, because of foreign body or tumor, both the curves are flattened or truncated and you get a boxed type of curve. Absolutely right, S. This is a fixed type of curve. Oxygen hemoglobin dissociation curve, right shift. This will be increase in PCO2, increase in H+, decrease in pH, increase in temperature, increase in 2,3-BPG and hemoglobin S. Increase in 2,3-BPG will be seen acronym GITA, excess of growth hormone, exercise, thyroid hormone, anemia, high altitude and androgens. Left shift will be decrease in PCO2, decrease in H+, increase in pH, hypothermia, decrease in 2,3-BPG, hemoglobin F and myoglobin. Hemoglobin F curve will be to the left of the normal. This is the HbF oxygen dissociation curve. Why is the HbF curve to the left of normal? This is because HbF is alpha 2 gamma 2. And remember, the gamma chain of HbF has a lower affinity for 2,3-BPG and a higher affinity for oxygen. And the myoglobin oxygen dissociation curve is like this. The shape itself is changed. It is a rectangular hyperbola. That is because myoglobin and oxygen have a very, very high affinity. Remember, right shift means a lower affinity, more delivery. Left shift means more affinity, more association. How do I remember this? FDR favors delivery or disassociation, shift to right. FAL favors affinity or association, shift to left. Why increase in 2,3-BPG causes a shift to right? This is because 2,3-BPG and oxygen bind at the same point on the beta chain of hemoglobin. More 2,3-BPG, less affinity for oxygen. Less 2,3-BPG, more affinity for oxygen. This has been asked, why is the HbF curve to the left of normal? That is because of the gamma chain. Gamma chain of HbF has a lower affinity for 2,3-BPG and higher affinity for oxygen. In carbon monoxide poisoning, there is going to be a decrease in the hemoglobin saturation and there is carbon monoxide will decrease the 2,3 BPG, and there is a shift of the curve to the left. As you can make out, a decreased saturation of the hemoglobin with oxygen, because what is the affinity of carbon monoxide and heme? More than 200 times the affinity of oxygen and heme. So once carbon monoxide binds with the heme, remember each hemoglobin has got 4 heme. Once carbon monoxide binds with the heme, it cannot be displaced. So what will happen to the hemoglobin saturation with oxygen? Reduces. As you can see, the height of the curve is reduced. And the curve is shifted to the left. Why? Because carbon monoxide decreases 2,3 BPG and causes a shift of the curve to the left. CO2 response curves at various fixed values of alveolar PO2. Now this is the graph between alveolar O2 and ventilation. When the, this is alveolar CO2 and the ventilation. This is seen when alveolar O2 is normal, 100. What does this tell you? It's a linear relationship. More the CO2, increase in CO2 will stimulate the chemoreceptors, peripheral more, central more than peripheral. There is increase in the rate, increase in the depth of ventilation. That means there is an increase in the total ventilation and increase in alveolar ventilation. Right? So we find that more the CO2, more is the ventilation. But if the PO2 is simultaneously reduced, we find there is an increase in the slope of the curve. So this indicates increase in CO2 will definitely increase ventilation without a doubt. But simultaneously, if it is associated with decrease in O2, there is an increase in the sensitivity of the chemoreceptors to the CO2 levels. This is what this graph is telling you. See, by change in the slope means there is an increase in sensitivity. Have you understood? When PO2 is normal, this is a normal PO2. You increase the CO2 levels, ventilation will increase without a doubt. But if you also reduce the PO2, first to 55 and then to 40, we find that the slope increases. That means the sensitivity of the chemoreceptors to increase in CO2 has increased. There is an increased sensitivity of the chemoreceptors to increase in CO2. This is what it means. Right. Let's look at some renal questions. Okay. The relative filtrability of 3 types of dextrans, neutral, polyanionic and polycationic of different molecular radii is depicted below. This is for neutral dextran. So basically what I'm trying to ask you over here is that on the x-axis you've got effective molecular radius and you've got relative filtrability. By the way, this graph was also asked as an INI-CET question. So that means if I take a dextran of, let's say, effective molecular radius of 30, this is the filtrability of A. This is the filtrability of the neutral dextran, and this is the filtrability of the dextran B. Now A is what and B is what? Remember, the glomerular filtration membrane, which is made of 3 layers, glomerular capillary endothelium, basement membrane, and the visceral layer of the Bowman's capsule, which is modified to form the podocytes. The basement membrane has got a negative charge. So it will repel the negatively charged substances. So negatively charged substance will have the least filtrability. So A is probably an anionic dextran. and B is a cationic dextron. Like charges repel, unlike charges attract. So if I take a dextron of the same molecular radius, one is neutral, the other is anionic, the third is cationic, the least filtrability will be for the anionic dextron, and maximum filtrability will be for the cationic, even if the radii of all the three is the same. So A will be polyanionic dextron. This is what this graph says. Okay. What are the pressures which are responsible for filtration? PGC, PyGC, PBC and PyBC. Which are the pressures which are favoring filtration? Favoring filtration are PGC and PyBC, and which are the ones which are opposing filtration? PYGC and PBC. Hydrostatic pressure of the glomerular capillaries is the most important force which is favoring filtration. Opposing this is the colloid osmotic pressure of the glomerular capillaries. The hydrostatic pressure of the Bowman's capsule also opposes filtration, as you can make out from the direction of the arrows. And PyBC favors filtration. So what is going to be my net filtration pressure? PGC minus PyGC minus PBC plus PyBC. Remember, the forces favoring filtration will be positive, that is PGC and PyBC. Forces which are opposing filtration, PyGC and PBC, will be negative. All right. As you can see from this slide here, the PyGC shows you an increase, afferent arteriole, efferent. Towards the efferent arteriole, the PyGC has increased. Why has PyGC increased? Because as the blood flows from the afferent arteriole glomerular capillaries into the efferent arteriole, there is filtration which is taking place, yes, in the glomerular capillaries. But what is not being filtered are the proteins, and these proteins are responsible for the colloid osmotic pressure. Everything else is being filtered. Glomerular filtrate is an ultrafiltrate of plasma. It is the same thing as plasma, except it has no plasma proteins. So what is not being filtered are the proteins, and proteins are responsible for the colloid osmotic pressure. So what is happening to the colloid osmotic pressure of the glomerular capillaries from the afferent to the efferent arteriole? It is increasing. And this has been asked as a question also, from afferent to efferent arteriole, which of the following pressures will show you an increase? PGC, PyGC, PBC or PyBC? Your answer is PyGC, colloid osmotic pressure of the glomerular capillaries. This is an interesting graph which is showing you that between a mean arterial pressure of 90 and 220 millimeters of mercury, the renal blood flow and GFR are constant. This is because of autoregulatory mechanisms. Renal blood flow and GFR will be constant. What are the pressures? 90 and 220 millimeters of mercury. That's exactly what I've showed you here. Between 90 and approximately 220 millimeters of mercury, the renal blood flow as well as the GFR are going to be constant. This is coming almost to the end of our discussion today, and that is the renal clearance. Now, what is the general formula for clearance? Clearance of a substance X. Firstly, what is the definition of clearance? Volume of plasma free of a substance in unit time. And what is the formula for clearance? Urinary concentration of X into rate of urine flow divided by plasma concentration of X. Urinary concentration is in milligram per ml. Rate of urine flow is in ml per minute. Plasma concentration will have similar units as urinary concentration. Both will cancel out. Finally, the unit for clearance is ml per minute. Volume of plasma free of a substance in unit time. Now, this is a graph which is showing you clearance against plasma concentration. C is the clearance of inulin, which is equal to GFR. Why inulin clearance is used for the estimation of GFR? Because inulin is a substance which is freely filtered, not reabsorbed, not secreted. So the rate at which inulin is cleared is the rate at which it is filtered. Any substance which is reabsorbed will have a clearance which is lower than the clearance of inulin, and a substance which is secreted will have a clearance which is more than the clearance of inulin. D is the clearance of glucose. C is the clearance of B is the clearance of creatinine. Creatinine is a substance which is freely filtered and slightly secreted. So its clearance will be slightly more than the clearance of inulin. A is the clearance of para-aminohippuric acid. At low concentration, very high clearance of para-aminohippuric acid, because the para-aminohippuric acid is freely filtered and completely secreted in low concentration, and its clearance is equal to the renal plasma flow. But as the concentration of para-aminohippuric acid increases, its clearance starts reducing because there is incomplete secretion of para-aminohippuric acid. So once again, C is the clearance of inulin. D is the clearance of glucose, because glucose is reabsorbed, so its clearance will be lower than the clearance of inulin. B, bravo, is the clearance of creatinine. Why? Slightly more than the clearance of inulin, because creatinine is a substance which is freely filtered and slightly secreted. A is the clearance of para-aminohippuric acid. In low concentrations, very high clearance. In higher concentration, the clearance reduces. Let's have a look at tubuloglomerular feedback. This is a mechanism of autoregulation of GFR. 3 or 4 important questions have been asked from here. When there is an increase in GFR, there will be increase in the sodium and chloride load in the tubular fluid. This is sensed by the macula densa. This has been asked as a question. What is the sensor of the tubuloglomerular feedback? These are macula densa cells. And what is the macula densa? These are modified tubular epithelial cells. At the beginning of DCT. These act as a sensor. They detect sodium and the chloride load in tubular fluid. So more sodium and chloride load in the tubular fluid sensed by macula densa, there is more reabsorption of sodium and chloride by the macula densa cells. More sodium reabsorption means more sodium potassium ATPase activity, which causes more breakdown of ATP, more generation of adenosine. Adenosine acts on A1 receptors on the macula densa. It causes release of calcium. This calcium will act on the afferent arterioles, which causes a constriction and reduces GFR. So 3 or 4 important questions. First, what is the sensor for TGF? Macula densa. Where is the macula densa located? Beginning of DCT. What does it sense? Only sodium, only chloride, or both sodium and chloride? Both sodium and chloride. TGF is mediated by adenosine. Site of action of TGF is the afferent arteriole. There is a vasoconstriction and a decrease in GFR. Let's see This is an important renal function curve which shows you if the sodium intake is normal, more the pressure, more will be the renal output. This is what is known as the renal function curve. This is also called pressure natriuresis and pressure diuresis. Coming back to the last graph for today, and this is what will happen to the TF, tubular fluid by plasma ratio, for different substances along the PCT. Now, to understand this, when you look at the glomerular filtrate, the filtrate is isotonic. It has the same composition as plasma, except it has no plasma proteins. Now, as the filtrate passes through the PCT, glucose and amino acids are reabsorbed to the extent of 100%. Bicarbonate will be reabsorbed to the tune of more than 80%. Urea is reabsorbed to the tune of about 40 to 50%. Electrolytes, sodium, chloride, this is about 60%. Water is about 66%, 2/3. So that fluid at the end of PCT continues to remain isotonic. Well, how does it remain isotonic? Total solutes and total water reabsorption in PCT is to the same extent. So the fluid at the end of PCT continues to remain isotonic. Now, please understand, for substances which are reabsorbed more than the reabsorption of water, the TF by P ratio will be less than 1. See, how can the tubular fluid by plasma ratio will be equal to 1? Tubular fluid concentration and plasma concentration of the substance will be the same if the reabsorption of the substance and reabsorption of water is the same. If reabsorption of the substance is more than the reabsorption of water, then the tubular fluid concentration of that substance will be lower than its plasma concentration. For substances which are reabsorbed to a lesser extent than water reabsorption, the TF by P ratio is more than 1. So, urea and electrolytes will have a TF by P ratio more than 1. Now, the substance is reabsorbed less than the reabsorption of water, so tubular fluid concentration of that substance will be more than that in the plasma. So, as you can see over here, a TF by P ratio of 1 is for osmolality. At the end of PCT, tubular fluid osmolality and plasma osmolality is the same. For glucose, for amino acids and for bicarbonate, the TF by P ratio is less than 1. For sodium, chloride, urea, TF by P ratio will be more than 1. For inulin, it is very high because inulin is not being reabsorbed at all. Water is being reabsorbed, but inulin is not being reabsorbed. So, TF by P ratio at the end of PCT for inulin is almost 2.5. But the highest TF by P ratio will be for para-aminohippuric acid. Why so? Because para-aminohippuric acid is freely filtered and completely secreted in the PCT. So, maximum ratio will be for para-aminohippuric acid. Once again, for tubular fluid by plasma ratio of any substance, you have to look at the relative absorption of that substance and water. If both are absorbed to the same extent, TF by P ratio is 1. If the substance is reabsorbed more than the reabsorption of water, its tubular fluid by plasma ratio will be less than 1. If the substance is reabsorbed less than the reabsorption of water, TF by P ratio will be more than 1. So, this has been a longish session for physiology today. A lot of important PYTs have been discussed today. Please follow this, please go through this again. This is especially important just before the exams. It will be a wonderful way to recap all the important topics as far as your INI-CET exam is concerned. Right, so thank you very much for all your cooperation. Thank you very much, and good night. Thank you and all the best.